So good afternoon and welcome to today's session, CDC's PrEP, Clinical Practice Guidelines and Strategies for Ending the HIV Epidemic in the U.S. My name is Elizabeth Breidenbach. I'm a meeting and event specialist based in the Clinical Affairs Division here at NAC, and I'm pleased to bring you this event along with my division colleague. Before we get started, I would like to review a few housekeeping announcements. You have joined this online event by either physically calling in or using computer audio. All attendee lines have been muted and will be muted for the duration of this event. The duration of this live event is approximately 60 minutes, including introductions, presentation, and of course, Q&A. Again, the duration of this live event is approximately 60 minutes. We do have the chat box located in the lower right-hand side of your computer screen. We did have some questions submitted in advance. Thank you so much for that. But if you have a question throughout today's session, feel free to pop that into the chat box. Again, simply type your comments, questions, or concerns and hit enter. We will try to attempt to answer as many questions as we can if time permits. If for some odd reason we need additional resources to answer those questions or we need to reach out to you individually, an attempt will be made after the event has been completed. Friendly reminders, like I said, the event is being recorded and will be available for playback. All attendee lines have been muted. Chat box is open, located in the lower right-hand side of your computer screen. Simply type your comments, questions, or concerns into this box. And of course, like I said, we'll answer questions at the end of today's session or after the event has been completed. At this moment, I'm going to turn things over to Pedro, who's going to be introducing today's speaker. Pedro, the floor is yours.
Hi, everybody. Thank you so much for attending our webinar today. It's part of our HIV prevention series. This is the second one. We're very happy to have Dr. Demetre Daskalakis, who is the CDC's Director of the Division of HIV/AIDS Prevention in the National Center for HIV/AIDS, Viral Hepatitis, STD, and Tuberculosis Prevention. Dr. Daskalakis began his career as a community health physician, and most recently he served as the Deputy Commissioner for the Division of Disease Control at the New York City Department of Health and Mental Hygiene. And after a stunning term there, he now is leading our country and our community at large in the field of HIV prevention. And we're very excited to have him here today. So I'll pass it over to you, Dr. D. Thank you so much.
Great. Thank you, Pedro, and nice to see you again. I'm really excited to be here to share our PrEP Clinical Practice Guideline, as well as talking a bit deeper into some of our strategies to end the HIV epidemic. So next slide, please. So I'll start by just talking about our agenda for today. So I'm going to start by really level setting and talk about the status of HIV in the United States. I'll also give you a spoiler and tell you that our new data is coming out really soon. I will then talk about the role of ending the HIV epidemic and where PrEP fits in to that strategy. I will take a dive into the PrEP guideline, and there will be time for questions at the end, but I'll try to go through all the highlights, really focusing on what's new and different, and also what's not different. So I think those are important. I'll talk a bit about future opportunities and resources, and then, as I said, go a little bit deeper into the story of our strategies to end HIV. Next slide, please. So as promised, I'll talk a bit about the status of HIV in the United States. And again, I will give you the spoiler that any day now, you'll be seeing new data coming from the Division of HIV Prevention at CDC. Next slide, please. So until then, we have data that are complete and public through 2019. I think it is important to note that there has been progress made in the number of new diagnoses of HIV in the jurisdiction in the United States. So we have gone down 8% from 2015, but that still means that we have about 34,800 infections that were reported as new diagnoses in 2019. So we have more work to do, although there is progress. And when we look specifically at what's happening in the United States, next slide, please. It's important to acknowledge that many of the challenges that we face in ending the HIV epidemic really walk in the footsteps of the racism, sexism, homophobia, transphobia, and regional disparities that occur in the United States. There are 1.2 million people in the US that have HIV, and their health disparities persist. There are also about 1.2 million people in the United States who we estimate could benefit from PrEP, and disparities exist there. So when you just take a snapshot of the disparities, we see a higher HIV incidence among gay and bisexual men, Black persons in the United States, and Hispanic Latino persons as well. We have larger gaps in PrEP coverage among Black Americans and Hispanic persons. We have lower rates of viral suppression among American Indian, Alaska Native persons, as well as Black persons. And we have a higher prevalence of HIV among men who have sex with men and transgender women. Although outbreaks of HIV continue to be driven by sexual transmission, we are also seeing more HIV outbreaks among people who inject drugs. And that threatens a lot of progress that happened in that population over time. And this is at least partially driven by the syndemic of opioid and other drug use like stimulants. So beyond populations, there is also a geographic disparity. So you can see on the map on the right, the rates of diagnoses of HIV are higher in the areas that register as darker colors on the map. And so you see there's a clear disparity that occurs in the South. In fact, over 50% of all new HIV diagnoses in 2019 occurred in this region. So whether it's population or place or the combination of place and population, disparities exist, and it requires specific attention to equity to move the needle forward. Next slide, please. So I want to briefly talk about the CDC's approach to ending the HIV epidemic in the US with specific focus on pre-exposure prophylaxis or PrEP. Next slide, please. So our strategic goals at the Division of HIV Prevention overlap with the federal Ending the HIV Epidemic Initiative pillars. They are, for those who do HIV work, fairly straightforward. You have to test more people and do it quickly and in a way that is efficient and meets their needs. You have to treat people with HIV rapidly and effectively to reach sustained viral suppression. Two reasons for that. The main reason is it keeps people healthy. So treating HIV is important because it keeps folks healthy. A great added benefit of treating people living with HIV so they stay healthy is that they also don't transmit HIV to their sexual partners. Also known as U equals U, or undetectable is equal to untransmittable. Prevention is also a key piece of our strategy and a main pillar in the work to end the HIV epidemic in the United States. So when I think about prevention, we talk about pre-exposure prophylaxis, which will be the focus of today's conversation, but it's also important to remember the critical role of syringe service programs where they are legal and allowable. And then finally, response. So to respond quickly to potential HIV outbreaks is really important. When we see rapid transmission of HIV in a population, it means that our system has failed them. And really working to improve prevention and treatment and testing services to specific populations is critical. And our ability to see clusters and respond to the people who are in them, as well as address the systems gaps, really allows us to fine-tune our population-based strategies, our testing, our treatment, and our prevention. Next slide, please. So I want to focus a bit on PrEP and some of the challenges that we're seeing. So again, although we are seeing overall progress toward ending HIV, as I showed you in previous slides, HIV continues to affect some groups severely and disproportionately. So rates of new HIV infections among Black people are over 8 times as high, and among Hispanic Latino people, almost 4 times as high as those rates of new HIV infections among white people. So to end the HIV epidemic, we need to scale up HIV testing, make sure that people with HIV are linked to care and getting treatment, and ensure equitable access to HIV prevention, and that does include PrEP, for everyone who could benefit. However, current PrEP coverage remains uneven across racial and ethnic groups, age groups, and for transgender persons. And in fact, in the slide that I'm showing you now, the disparity is actually increasing between white persons and Black and Hispanic Latino persons. So just to orient you, the red line represents the percentage of individuals with PrEP indications who are covered by PrEP. And you can see that 60.7% of white people with indications. When you look at Hispanic and Black, you'll see that it's 14 and 8% respectively. And that really does not sync with the proportion of new diagnoses that are occurring on those populations. So that's a clear disparity. So again, it's really critical to strategize ways that we can increase PrEP coverage with an equity focus so the populations overrepresented in the epidemic are also represented appropriately in our PrEP coverage. Next slide, please. And as I said, it's not just about race and ethnicity. We also see gender gaps. I'll start by saying these data are limited by the source. It does not focus on gender identity, but just sex at birth. When you look at this, you can see that PrEP coverage is unevenly distributed among people based on sex. So among people for whom PrEP is recommended, PrEP coverage was about 3 times as high in 2020 among males as among females. Cisgender women represented about 19% of new HIV diagnoses in 2019. So addressing this imbalance is critical. So again, 19% does not equal 9.6. So there is an inequity that really focuses on sex at birth. Next slide, please. So when you look at PrEP specifically and these inequities, only 10% of women who could benefit from PrEP were prescribed it in 2020. Only 27% of Black or African American, 31% of Hispanic or Latino, and 42% of white, gay, and bisexual men surveyed by CDC who could have benefited from PrEP used it. So this is a different data source than the prescribing data. So you can see, again, surveys show that we still have gaps and, again, disparities based on race and ethnicity. Also, this is one that I think is really important to remember as well, and I think also represents some of the challenge. So among transgender women who were HIV negative, surveyed in our national HIV behavioral surveillance, 92% had heard about PrEP. 32% of them had actually used it in the past 12 months. So I'll just step back and say 32% is pretty good, but we can do better. There's a gap between knowledge and actual utilization. So not only is it about increasing access, but it's also about increasing confidence in the intervention, in the distribution of the intervention, the prescriber, and ultimately the system that supports prevention. So these are really important numbers to keep in mind as we go forward and talk about our strategies to improve PrEP uptake and specifically some of the important changes in the guideline that encourage this. Next slide, please. Now, I can't talk about PrEP without talking about treatment. So we know that treatment as prevention or TASP, also known as undetectable is equal to undetectable, undetectable is equal to untransmittable, is a critical intervention that helps people with HIV stay healthy while preventing HIV transmission. When you put PrEP together with HIV treatment, we really do have a biomedical combination of interventions that can really allow us to see the end of the HIV epidemic despite not having a cure or a vaccine. Saying that as well, we need a cure and a vaccine. So ensuring that people know their HIV status, that testing step happens is critical and allows for the opportunity, whatever the result of the test, to improve their health and engage in prevention and care. So regardless of status, it's our clearest path to achieving the goal of ending the HIV epidemic and controlling it well beyond when we've achieved that numeric end. Next slide, please. So I'm going to move on and talk a bit about the PrEP guideline. Next slide. So like I said, it's important to talk about things that have changed, but also to emphasize what hasn't changed since the 2017 guideline. So there have been no changes to the indications for PrEP use. There has been no change in the frequency of follow-up visits for oral PrEP. We're going to talk about injectables shortly. And there has been no change in the schedule for HIV and STI testing for oral pre-exposure prophylaxis. So for those of you who don't know, there are 2 oral drugs approved for pre-exposure prophylaxis and now 1 injectable. Their schedules are a bit different, but nothing has changed from the schedule perspective for oral PrEP. Next slide, please. This is a really important new part of our guideline. There is a new recommendation that's really designed to increase awareness of PrEP within the primary care and other environments. The new recommendation is that all sexually active adult and adolescent patients should receive information about PrEP. So there's a lot of reasons why we're doing this. It encourages providers to offer PrEP as a core primary care service and reduces missed opportunities for PrEP provision. We're trying to do better of embedding this into the fabric of primary care service. It also increases knowledge of PrEP among potential users. So that allows for people to either immediately decide if they want to go on pre-exposure prophylaxis or have awareness of scenarios where it may benefit them to go on PrEP if there are changes in their sexual or drug-using lives. Also, it increases knowledge of PrEP in the community. So a lot of us walk around and really spread the word about PrEP no matter where we are, whether it's in an Uber or among friends. So we think that there's definitely something to be said for the person-to-person interaction that happens. So the idea that more people learn about PrEP means that more people can actually share PrEP and the idea of pre-exposure prophylaxis to others, whether they're family, friends, or acquaintances. Next slide, please. So I want to talk briefly about the daily oral pre-exposure protocol. And this really focuses on prescribing and lab testing. So we'll start with that first column and talk about the PrEP initiation visit. So for daily oral pre-exposure prophylaxis, it starts with an HIV test. And that ideally is an HIV antigen antibody combo test that's performed in the laboratory. I'll also mention that there are same-day start options described in the guideline as well, which I'll refer you to. In terms of kidney function, it's important to check kidney function when starting daily oral PrEP. And really, depending on kidney function, there will be different recommendations for what drug to start. So if someone's kidney function estimated creatinine clearance is greater than 60 mils per minute, you can start a TDF-based regimen, also known as Truvada and the generics, or a TAF-based regimen, which is also known as Descovy, no generic available yet. If there is a renal function that's lower but greater than 30 mils per min, then Descovy or TAF FTC becomes the option. There also needs to be screening for STIs, and it depends on the population what you do, but syphilis, gonorrhea, chlamydia are among the tests to order. There is a recommendation for a lipid screening, not for TDF or Truvada and other generics, but for Descovy because of some possibility of increased lipids in the future. A need for a hepatitis B serology, and then a prescription for 90 days. Follow-up visits for oral pre-exposure prophylaxis happens every 3 months. And there is a change in the guideline here. The recommendation is to order a HIV antigen antibody test, again, ideally a lab-based test, but to supplement that with a qualitative RNA. So another test to look for direct viral detection. And that is really because there is a disconnect in some studies between time of seroconversion on the serologic test and when virus becomes detectable. So it is really to have a zero tolerance for missed HIV infections in follow-up. From the kidney perspective, another important change, if people are over 50 or have a creatinine clearance that's less than 90, they should get their kidney function rechecked every 6 months. If, however, they're under 50 or they have a kidney function that is over 90, they can get their kidney function checked every 12 months. So that's a change. It used to be everyone was getting checked every 6 months. Again, on follow-up visits, there are STI recommendations that really focus on specific populations. For people who are on Descovy or the TAF-based regimen, you have to repeat lipids every 12 months, which is very much in line with good primary care anyway. And then also at that point on the follow-up visits, another 90-day refill is prescribed for follow-up. Next slide, please. We also have another PrEP dosing regimen. It's often called 2-1-1 or event-driven PrEP. So this is a regimen that is not recommended by the guideline, but we give the roadmap for how to do this in case there is a population or group for which it makes sense or an individual for which it makes sense. So this dosing regimen is not FDA approved. This is an off-label schedule for offering oral pre-exposure prophylaxis. Event-driven PrEP is only for adult men who have sex with men, so other gay, bisexual men and transgender women who request non-daily dosing, have sex infrequently, so less often than once a week, and are able to anticipate sex or delay it to permit for the 2-1-1 dosing strategy. And in case you can't see that slide very well, what that means is 2 to 24 hours before sex, take 2 doses of TDF-based PrEP, so that's the Truvada or equivalent generics. Sex happens, and then 2 more days of daily PrEP after. So it is 2-1-1. The way that we recommend that you do this is that you prescribe TDF-based regimen, whether it is Truvada or the generics, with a 30-day supply and have that happen before the next HIV test. And also, it's really important to have a conversation about how to safely switch between daily and 2-1-1 dosing. And that is all very clearly described in the guidelines. So I refer you to that for more detail. Next slide, please. So now I'm going to talk a little bit about the new injectable PrEP, also known as cabotegravir or Apretude as a brand name. So in the initiation visit, there's a little bit of a difference. In this one, it's not just an antigen antibody test. There is also a qualitative or quantitative viral load or RNA that's done at that time. And the reason is that you really want to rule out acute HIV infection before you give someone a drug that has an extraordinarily long half-life. And so it's really making sure that the screening is complete, that they do not have an undetected acute infection, and then that should be the initiation of the medicine. STI screening is also included, and you'll see a couple of things have fallen off. There's nothing about lipids here. There's nothing about kidney function because they're not necessary for cabotegravir. Provide cabotegravir injection at the initiation time, which is ideally after you know that their viral load and HIV test is negative, and then again 1 month later. So it's the first is start it, come back in a month for your other injection. Subsequently, it moves to every 2 months. And the follow-up visits, again, include an antigen antibody test, as well as a qualitative or quantitative RNA, so another viral load test. You will also do STI screening. This is going to be every 4 months. So since people are coming back every 2, the schedule is a little bit different than the oral. You're not going to do STI testing every 2 months. You're going to do it pretty much on every other visit. And then provide cabotegravir. And as I said, after that first 2 months where it is a monthly dose, it moves on to an every 2 month dose. And that, of course, depends on dosing if the HIV test is negative. Next slide, please. So I also wanted to highlight some really important future opportunities for PrEP. Next slide. So the first is that, as I said to you before, one of the goals of the guideline, based on the evidence, is to really incorporate PrEP deeper into primary care. The U.S. Preventative Services Task Force assigns PrEP a grade A recommendation for primary care preventative care. That's followed by CMS that has an FAQ that supports that both the medicine, so the drug, and the clinical services that support PrEP should be covered by insurers without any out-of-pocket costs to the patient. That translates into no copays, which is great news. We also know PrEP is a highly effective primary care intervention, but we need more providers to educate their patients about PrEP and prescribe it. And I do also want to mention that the guideline makes one really important point. If a patient says, I want to go on PrEP, that is enough to start them on PrEP. If you actually look at our guideline and the flowcharts that are developed around decision-making, the request for PrEP is enough to initiate. So there's no need to explore a deeper risk history if people are unwilling to share. Often people may not share the details of their sex and drug using life, but if they're asking for PrEP, it probably means that they have indications. So very low threshold to start people on PrEP. Next slide, please. Now, one of the important things we have to work on, and part of this is happening right now by really messaging around our new guidelines and really the fact that PrEP is actually easy to do and can easily be incorporated into the flow of primary care practice, is that we have to increase the number of PrEP prescribers in the United States. So I'll say we're making progress. So in 2019, there were 66,000 PrEP prescribers, and that is more than 6-fold higher than 2014. about 70% of them were physicians and 30% were nurse practitioners or PAs. So these stats that I'm about to tell you are really a call to action for us. Among all active providers, only 4% had prescribed PrEP. Now, I assure you that more than 4% of providers have people who could benefit from PrEP in their practice. And so the goal of making this more straightforward in primary care, I think, is really important. And really to put it up there along with smoking cessation, along with pre-diabetes screening and treatment, like we can do this because we do it in other diseases and with other areas where we can prevent bad outcomes. The 4% of active providers that have prescribed PrEP were also stilted more toward infectious disease physicians. Now, they don't always see the right patients. So they're really important because they can help spread the word and teach about PrEP, but really family practitioners and other primary care providers, including folks that do women's health and drug user health, they're the ones who are seeing people who could benefit from PrEP even more than an ID physician. Only 13% of those providers who prescribe PrEP were family practitioners. So again, a rallying cry to see if we can increase PrEP prescribing among primary care doctors and folks who do general medicine. Another rallying call is that 50% of PrEP patients receive their PrEP prescribed by 3% of PrEP providers. So in other words, we need to spread the wealth. I think there are a lot of folks who see the right patients, and we really need to work to increase people's comfort with prescribing PrEP, and also identifying ways to communicate with their patient population to make them aware of PrEP so that they can move seamlessly into that intervention if it is needed. Next slide, please. And I think that there are a lot of exciting future opportunities for PrEP. So we have just begun in terms of the riches of choices that are coming our way. So we used to have one pill. Now we have 2 pills, we have alternate dosing options for those pills, and we also have an injectable. More coming down the pike, longer acting agents, injectable, longer acting injectables, and even implants are coming down the pike. And so very exciting. It also means that we have to understand how people make choices, whether those are providers or patients. And so we're doing research now to identify like where choice fits in and how ideally people will move between various interventions. And we're hopeful that the U.S. Preventative Services Task Force will be reviewing injectable PrEP to see if potentially it could also be identified with a grade that allows it to be covered without responsibility for coverage. So all of that is coming, and it's all very exciting. Next slide, please. I want to talk a bit about PrEP-related resources. Next slide. So first, I wanted to talk about the CDC's HIV campaign, Let's Stop HIV Together. So this is a status-neutral campaign that focuses on all aspects of HIV treatment and prevention, whether it's testing, treatment, PrEP, etc. It really focuses on stigma and patient-centered care, testing, prevention, and all of the various strategies that are part of ending the HIV epidemic. And it has materials that face both consumers and clinicians. So it's available on our website, so please take a look. Next slide, please. There are also some great resources for clinicians. And one that I really want to make sure I highlight so you know that it exists is the PrEP line. So this is a PrEP line where you can call if you have clinical care related questions. So it's 855 HIV PrEP. Or 855-448-7737. It is toll free. Along with clinical care questions, you also get access to advanced diagnostics in the scenario that there are any ambiguous test results or persons who may acquire HIV while prescribed PrEP. So making us aware of those is great, so we can understand if there's been a PrEP-related issue or a failure of the drug to prevent HIV. Also, it would refer you to the NASDAQ billing and coding guide, really helpful in terms of understanding how to bill. And I will give you a deeper dive into our HIV Nexus. Next slide, please. So Nexus is available at cdc.gov/HIV Nexus. It's a clinical resource, and it serves as a one-stop hub for resources designed to support clinicians. It's great. It contains latest research and information on HIV prevention, screening, and treatment, and provides access to pre-CME, so continuing medical education programs. It also highlights CDC guidelines, such as the one that I just discussed, and also recommendations. But it also provides a really easy link to getting patient education materials that could potentially help to communicate the role of PrEP and other interventions. Next slide, please. I also wanted to highlight that there are some ways to help patients pay for PrEP care if they are uninsured. One really good way is to point them toward insurance. So if you have a patient who could get commercial insurance, they will have no out-of-pocket costs for medication, clinical care, and lab tests. And that again is based on the Preventative Services Task Force Grade A, as well as the CMS Department of Labor no-cost coverage rule. For uninsured persons, again, identifying an insurance product through healthcare.gov is great, but if they can't do that, there are pathways to get free medication. There is the Ready, Set, PrEP program available at hiv.gov, and there are also medical assistance programs that are provided by the manufacturers of the drugs that are approved for pre-exposure prophylaxis. Next slide, please. I also want to make sure that you've heard that CDC did a policy analysis, and we have made it allowable for health department resources to pay for PrEP care. So PrEP ancillary support services are now allowable using CDC HIV funds that are going to health departments. And up to 15% of their budget can go toward support of PrEP ancillary care. That can include lab costs, navigation, mobile units, etc. Now, it does not cover the purchase of PrEP medications, but as I told you, there are other strategies, including Ready, Set, PrEP and manufacturer programs to access the drug. So really good news that health departments are able to use resources to cover PrEP. Next slide, please. And I wanted to just cover briefly some of the priorities that we're focusing on that are really critical in advancing PrEP in the United States, as well as our other interventions. Next slide, please. So we are focused on the 4 pillars, which I talked about. So test, treat, prevent, respond. But there are other priorities that are critical in moving all of these forward. So one is to prioritize health equity and weave it better through the work that we do in our HIV prevention portfolio. Work harder to get tests to people the way that they want them, and that may include self-testing. So we'll talk a little bit about that. Expanding our view and not just focusing on HIV, but strategies of how we can weave things together into more syndemic response, which takes into account hepatitis, STIs, drug user health, transgender health, etc. And then ultimately, how we can put that all together in a way to help create a delivery system that makes sense and is based not on status, HIV negative or positive, but on population needs. So how can we create a system that's more about what people need rather than funding silos that really focus on status as opposed to service delivery needs? Next slide, please. So I'll talk briefly about the status neutral approach here. So when I say status neutral, next slide, please, I'm referring to the idea that really our service delivery system should focus on a whole person approach and not be focused only on an HIV status. So in many ways, knowledge of status opens the door. And so if someone is diagnosed with HIV, they can engage in a treatment pathway. The result of being engaged in a treatment pathway is they go on the medications that they need to keep themselves healthy, and then they don't transmit HIV to their sexual partners because of viral suppression. If they test HIV negative and have indications for prevention interventions, they enter a prevention pathway, and they're assessed and reassessed for the need for pre-exposure prophylaxis, along with all the appropriate STI and HIV testing needed to make sure that people really maintain a healthy life, whether it's sexual or related to drug use. Ultimately, engaging in that prevention pathway means that people will get on PrEP if they need it. And again, they are less likely to get HIV. All of this is wrapped around in an aspirational strategy of trying to provide the correct services whether they're social or medical, that meet the needs of the population. That means syndemic-related interventions. It means drug user health, transgender health, really embedding it into a place where HIV becomes a part of the care delivery rather than something that is foreign or separate. Next slide, please. So we're advancing status neutral care in several ways. So one is that we're encouraging integrated service delivery, and that is both through the work that we're doing with our health departments, through our Ending the HIV Epidemic, as well as flagship funding, but also work that we're doing with our community-based organizations with special focus on some of our directly funded organizations that include over 90 CBOs that provide general service and another 36 that provide service specifically to young men who have sex with men of color or transgender women of color, with the goal of really weaving things together in a way that serves the whole person and approaches a more status neutral vision of service delivery. We're also conducting implementation science, and I'm really excited. We're soon going to announce recipients of a pilot program that is really focused on provision of status neutral HIV services in transgender health environments. So it's the idea of what happens if you take that model, that status neutral model, and actually embed it into a place where people are already getting their transgender related health. I think it's going to give us a lot of important information and best practices of really creating a one-door strategy where whether you're living with HIV or could benefit of PrEP, if you enter the system, you get what you need regardless of your status in an environment that is culturally responsive and addressing your other needs. We're also working hard to build partnerships because a status neutral vision isn't just about care, it's about service provision. And so we're excited with the work that we're doing with our colleagues in housing and other parts of the federal government to better integrate services across HIV status. So really exciting movements. Keep an eye on this space. There is a lot more support coming, technical assistance, as well as some documents called issue briefs that will focus on the status neutral framework and really thinking about ways that you can really move things to a more status neutral place in your environment is really important, so we can move the needle on that one as well. Next slide, please. And I think I actually spoke about these already. We do have several new innovations, including the demonstration project and also support for PrEP ancillary services that allow us to go closer to a status neutral vision of service delivery. Next slide, please. I also wanted to talk about what we're doing to prioritize health equity. Next slide. So first, I'll highlight the work that we're doing internally to really improve equity within CDC, within our division in our center, and then also how that's going to reflect outwardly. So our center, the National Center for HIV, Hepatitis, STD, and Tuberculosis Prevention, has for decades been focusing on work to integrate equity into everything that we do. They, however, have taken a very highly intentional step of creating a new equity initiative that focuses on workplace culture, workplace policies and practice to really identify ways that we can make our workforce be more reflective of the individuals that we serve, as well as looking critically at our systems and processes for designing funding and evaluating research, programs, policy, and our partnerships. So again, it builds on decades of work, but it's all weaving together in a way to really focus more on equity and really hard outcomes. I'll say that this is also in the context of an agency-wide effort called CORE to do similar work. Next slide, please. So leaving the center level, which is the organizational unit above the division of HIV, within the division of HIV, where I'm the director, we're also working in a very similar path. We are working to create an equity, we have created an equity change team where individuals within our offices and our branches are actually given dedicated time as part of their effort to do work specifically focused on increasing equity within the division, as well as equity in the work that we do externally. So Part of this is being committed to the workplace. So we have focus on workplace culture, policies, and procedures, as well as our research policy programs and partnerships at the division. And so we're doing trainings like undoing racism that really allow us to have hard conversations about race and continue to host many town halls and other conversations to make sure that we continue to name the problem that both hampers our work as well as our progress to ending the HIV epidemic in the US. Next slide, please. The next priority I wanted to highlight was expanding HIV self-testing. Next slide, please. So I'll tell you about one of our really exciting efforts. So the CDC was awarded about $2 million in fiscal year 20 from the Minority HIV/AIDS Fund for HIV self-testing. That resulted in our ability to get about 100,000 HIV self-testing kits that we plan to distribute over 18 months. Well, it was a blockbuster, and they all flew off the shelves in 8 months. And what we found was that we found a movable middle of people who were potentially not testing in bricks and mortar or clinical environments, but who wanted to test using self-tests. About 26% of the people who ordered self-tests from us had never been tested for HIV before. So with that, we're really working hard to do to increase our work in online distribution of the HIV self-testing kits, as well as bricks and mortar distribution through community-based organizations to really address some of the issues of digital divide. So the notion being that when you come for a service at a community-based organization, you can get a self-test and then take it home for yourself and also for any of your friends, partners, or colleagues. Next slide, please. And lastly, I wanted to talk about strengthening syndemic collaborations. Next slide, please. So first, what is a syndemic? So a syndemic is a set of linked health problems that interact with each other, and they exist in an environment of social injustice that results in an increase in the amount or severity of disease in a population. So when we think about syndemics, systemic racism, sexism, homophobia, transphobia, and a multitude of other social determinants like unemployment and housing potentiate interactions to worsen the adverse effects of the way that these infections interact with each other and worsen community health. So it reminds me of something I learned when I was training for infectious diseases. One of my senior mentors taught me something in Latin, and I promise that it's the last time I'll say anything in Latin ever. And it's called locus minoris resistentia. So it's the idea that an injury can make a body area or part more susceptible to another and potentially worse injury. So as an example, if you twist your ankle and then that ankle heals and you're working out and you do something where that ankle could get twisted again, it's probably going to get hurt and potentially even worse unless you strengthen it. So that is really what our communities have been through. They've been injured by centuries of bias, minoritization, and have been made invisible. So we have to really address those centuries of injury to be able to make progress in the infectious diseases that we call syndemics. So the long-standing isms, phobias, and systems that maintain this are really a target of what we have to do to move forward in not only addressing HIV, but the other interacting scenarios, whether they're infectious or non-infectious, that potentiate the outcome. So we have to interrupt the cycle of injury to better control the syndemics. Next slide, please. So I'll say that CDC HIV prevention funding, guidelines, and technical assistance support syndemic approaches where diseases are actually interacting or connecting. There are lots of settings where we are able to do syndemic work, including syringe service programs, STI clinics, community-based organizations, health departments, and community health centers. There are areas of overlap, specifically testing, prevention, and linkage to treatment for STIs, viral hepatitis, and HIV. And we have flexible funding and are listening to our community that we've engaged with, really requesting us to think about how we can become even more flexible to allow for better coverage of other syndemic conditions. Next slide, please. And so when we think about our syndemic approach, it's really about people, about place, about science, and about policy. So who are the populations experiencing our syndemics? Where can we reach and touch them? Where are they geographically? What are the innovations that we can move forward? And really importantly, what are the policies that need to change or levers that we need to switch to be able to move things forward? Next slide. So simply put, critical to put people first, specifically populations, and think about who really are experiencing the syndemics. You can't do this without focusing on equity because syndemics only exist because of the inequities that allow them to be potentiated. We have to focus on our data. Where we are seeing our epidemic is where we need to focus our effort as well as our resources. We have to leverage policy as a public health tool. So there are important policy changes and levers that we need to pull to be able to really identify ways to move forward on some of the social determinants of health, and also any of the logistical areas that block us from our ability to optimize care across the syndemic conditions. And then finally, continue to innovate. So science is important, and having new strategies is really important, but also making sure that those strategies are deployed in the community in a way that is both respectful and responsive to their need. Next slide, please. So I want to end by saying we don't have a vaccine and we don't have a cure, but we still have an unprecedented opportunity to end America's HIV epidemic using tools such as pre-exposure prophylaxis, HIV testing, and treatment. Next slide, please. So with that, I will open the floor, hand it back to Pedro, and see if there are any questions.
Thank you so much, Dr. Daskalakis. I just wanted to say, you know, from being a producer and consumer of HIV prevention research and working in community health, we can clearly see the community voice on the updates to the PrEP guidelines, and even to guidance on like being able to pay auxiliary services in grants, because it's really huge when you are in the community health center and you're trying to come up with ways to help individual patients, right? And not really like maybe come up with a program for everybody. Anyway, so we do have a few questions that folks have submitted. And then, so I'll read the first one. And then if folks in the line have questions, you can raise your hand and then we'll call you, or also like, you know, can just unmute and ask a question. So the first question, I see it in the chat and we had somebody ask too. So it's about the long-acting injectable, the cabotegravir. There were concerns. Somebody said that they were hearing concerns about the placement of the injection, something about, so they mentioned that, but we also, just to kind of like plug in a second part of a question, if the CDC has any ability to work with CMS and private insurers to kind of harmonize the process of costs and issues related to paying for it. So
great, thank you. So first, I think that the discussion about in placement of the injection, the place that it's come up has been in individuals who have either silicone implants or injections in their buttocks. Specifically, it's come up because some transgender women and others actually do have this, and it's a contraindication to injecting the cabotegravir in their buttocks. There are studies happening now to look at alternate sites of administration, so specifically thigh. They're not out yet. So my hope is that once we have those data, that there will be a change in approval if the data are good, and that effectiveness is maintained despite a new site of injection. So I think that refers to that. In terms of working with CMS, we do work with CMS, so that's really important to say. I think that there's going to be a little bit of a period where CAB LA is going to be complex in terms of implementation. So definitely we will continue to work with them. And also as we get closer to Preventative Services Task Force decision on CAB LA, that may make everything a lot more streamlined. We expect that that decision will be in the next year. So I think it's fair to say that we'll continue to work with our insurance partners, but that there may be a little bit of complexity for a while until we get to a more stable place with such a new intervention. But that's a great question, and we're with you. I wish we could snap our fingers and make it better fast, but we're trying.
I see another question here from Sarah. Sarah, I'm gonna unmute you if you feel comfortable asking your question. I think it was in the context of something that was happening, but it might be. let us know. I'll give you a second. If not, I'll just read what's here. Okay, so I'll just read the question. So her question was about resources, additional resources to support primary care with screenings and addressing equity issues.
So I think I understand the question. So I know that there's a lot sort of in the screening universe in terms of resources, and it's complex. I think our effort to increase the ability to use CDC funds for PrEP ancillary services is an effort to at least try to address that. I think also, you know, a more permissive strategy, which is in the guideline for how people can do follow-up, is also, I hope, designed to lessen the impact on flow. So the notion of there being lab-only visits that are possible for people for PrEP that may potentially make things a bit easier. I think that there is always additional hope for resources, and I think really working to make sure that ending the HIV epidemic is adequately supported, I think is the bridge to that. And I think also keeping a close tab on what's happening with the president's budget. So there's a line in the president's budget about a national PrEP program. And so I think there's a lot of hope for a lot of resources and a lot of excitement over PrEP. But I hear and acknowledge that you are extraordinarily stretched thin. And I think especially post-COVID, it is tone deaf not to say that we know that there are a lot of other priorities that you all have. But I'm really working to try to integrate this into primary care is so critical that that attention that you pay to that, I think, is so important. So thank you. And again, working to get more resources and to sort of distribute resources in a way that makes sense and really offset some of the work in primary care, but also keeping a close ear to the ground for some of the opportunities that are rolling around.
And then I have another one. What are the type of conversations that we need to have with women related to PrEP?
Yeah, this is a great question. I feel like we have some pretty clear strategies for women. So I think one is offer them PrEP or discuss it, make them aware that it exists. And I think one of the things that we need to say is PrEP is not just for gay men. PrEP is not just an MSM or bisexual or gay or other same gender loving man intervention, that it is an intervention for sexually active people who might be at risk for HIV. So I think that that's a really important part. Also, I think when you have a woman who's diagnosed with an STI, that is a really great opportunity to discuss the role of PrEP. So I think that there's a lot of places, so especially if it's gonorrhea or syphilis, there's a lot of opportunities there. And I think it begins with talking about the intervention and making sure that part of the message is it's for women, it's not just for men. I'll say that I think that there's mixed messages that you hear because of the way PrEP is marketed. So, they're CAP FTC, so that the Descovy formulation hasn't yet been studied in women completely. So it's not indicated for women. And what happens is when all of the advertisements on television say, this is a PrEP drug and it's not for people assigned female at birth, like we really have to work against that sort of confounding of the message that it's not all PrEP that's not for women, for people assigned female at birth. That in fact, there is a drug option too now, whether it's a TDF-based regimen, so Truvada and generics, or a cabotegravir or Apretude injectable regimen. So I think probably the most important is let them know it exists and tell them that PrEP is for women and not just for men.
Okay, all right. I will ask one last question, and then if anybody else have a question, feel free to raise your hand. So the other thing that I think it's going to be maybe the next step, right, as we get more people aware and considering PrEP and talking to the providers, is people staying on PrEP, what we call persistence, right? And I think that has a lot to do with like making the system maybe easier for patients. So what are your thoughts on like, longevity of PrEP use and engaging patients for long term?
Yeah, I think that I have a lot to say on that. So I'll try to be brief. But I think a lot of it has to do with, especially in a primary care setting, just embedding PrEP in part of the rest of their routine care. So I use that transgender health example where if we made everything about PrEP, we're not going to get the transgender women to be interested in PrEP. But if PrEP becomes a part of transgender health, that's persistence. Like it's just a part of the conversation. It's part of that engagement in that preventative cycle that keeps people connected to care. And that means that they'll go on PrEP if they need it, go off if they don't need it, and maybe go back on if they need it again. So I think it's about those honest conversations and really trying to provide the other services that are needed to keep people persisting. And I agree, whatever we can do to simplify PrEP, I think is really important. And so I think that trying to really work with patients about their follow-up, figuring out if there's ways to do lab-only visits if necessary. People are busy, and again, like they're not sick. They're taking a medicine for prevention. So really trying to be flexible while also making sure that the appropriate testing is happening is I think the way to go. But also realizing that it's definitely not just about PrEP. It's about the other services that they need, whether it's sex health related. Is it contraception? Is it STI screening? Is it gender affirming care? Is it drug user help? Do they need to find out where they can get syringes if they need them? Like it's really about embedding it into a larger sort of prevention package, which is, as in my recollection, in my time as a primary care doctor, one of the things that we do really well.
Okay, we have one last question here. Can you speak to the tension between taking a zero tolerance approach to acute HIV infections while on PrEP, i.e. recommending qualitative viral load tests for people on PrEP, and potentially creating barriers to clinics and PrEP providers who don't have access to viral load tests? Did that make sense? Yeah.
It made perfect sense. So the guidelines are based on the data, and there are data that are from studies that show that individuals who are on injectable PrEP, sometimes who seroconvert, have a 90-day lag between their antibody antigen test and their viral load. So their standard HIV test takes about 90 days on average to become positive. And for oral PrEP, it's about 30. So there is definitely a tension, and it's important to acknowledge. The guideline is the guideline. And it's really based on if you have the availability, this is the ideal thing to do. If for some reason you don't have availability of viral load testing, that doesn't mean that you don't do PrEP. The aspiration is that you do get availability to viral load testing, and that's a systems issue. But from the perspective of PrEP provision, you then have to do the best HIV testing that you have available. So that means a lab-based antibody antigen is all that's available. That's what we're going to have to do, because PrEP is PrEP should be continued even if you don't have that other test available. With that said, CDC in the guidelines, folks, in PrEP really look at what the data are saying. So I gave you the example of the creatinine. So it was every 6 months, but when we saw that their data that people who are less than 50 and have creatinine clearances that are over 90 didn't really need to get as much follow-up for the testing, we eased off on the recommendation. Reality is we need to get more data under our belt around the utility of viral load, and we're going to do that over time. And so if we see that this is a less useful intervention, our guideline will also change in the future.
Thank you so much, Dr. D. We really appreciate having you here. And, we hope to see more from you and have you back sometime soon. Thank you.
Great. Thank you so much. Thanks a lot for having me, and have a wonderful rest of your day. Thanks, everybody. Bye-bye.
Bye.